Good afternoon. Welcome to our very first Facebook Live event, hopefully the one of many to come. Dr. Safa Kassab, I'm a member of Orthopedic Specialists of Oakland County. Firstly, I want to thank you all for joining us today, but I also hope that everyone is doing well, staying safe, and taking all the necessary precautions to help mitigate getting this virus, the COVID-19, and also spreading the virus. I know everyone is doing their part, and we all appreciate that very much. I know we're all coping with this situation our own way. For me, I'm coping by doing this virtual interaction with you. It's this COVID-19 pandemic has taken away the best part of my day, which is interacting with my patients one-on-one every day. I've been doing this for over 2 decades and have interacted and taken care of thousands of patients. And I'm proud to say that many of those patients are not just patients to me, but they're my friends. And I know we'll be back in no time, but for now, we have to kind of do it this way, virtually. And I appreciate you all joining in. First, a little bit about our practice. Orthopedic Specialists of Oakland County is a group of 5 orthopedic surgeons who ironically all grew up in the area. We treat things like musculoskeletal injuries, which are bone and joint injuries. I'm just looking at all the comments. I appreciate that. We all have our own subspecialty, which is called fellowship training. And so what fellowship training is, each one of us did an extra year after doing our orthopedic residency in a subspecialty in orthopedics. So even though we take care of general orthopedic problems, we also take care of subspecialty areas. We have Dr. Matt Bahu, who is a shoulder and elbow surgeon, Dr. Robert Howard, who is a foot and ankle specialist, Dr. Nicholas Schroeder, who is a neck, back, and spine specialist, and then myself and Dr. Joseph Ward, who are both adult reconstructive, and essentially that means that we take care of hip and knee replacement problems. So we have 2 locations, one in Clarkston, which is on Dixie, just south of 75 and north of White Lake Road. And we also have one almost directly across from St. Joe's Mercy Oakland and falls into Bloomfield, but it's kitty corner from the hospital. They both have physical therapy attached to them, and which is physician directed and owned and operated by our practice. To learn more about our practice, you can visit our Facebook page or click on the link to our practice, which we're going to put up in the comments page in just a minute. A little bit about me. So I grew up in the area. We grew up in Detroit initially, and we all moved to the suburbs. And I grew up in Southfield, did my schooling in Southfield. I attended undergraduate and medical school at Wayne State University. Used to be a Tartar, is what we were called back then. Did my residency at Detroit Medical Center in orthopedic surgery for 5 years, and then did a year of fellowship in adult reconstructive surgery at University of California, San Diego, where I did my joint replacement. My first and only job in orthopedics has been here. I took over a practice from Dr. Robert Nestor. Many of you probably know him. He grew up in the area and had a practice for a long time. I took over that practice almost 25 years ago. Best decision I ever made. And I wholeheartedly expect to retire from that practice. I can't imagine practicing anywhere else. I've learned during this pandemic that, again, this is one of the best parts of my day is to go to work every day and interact with my patients. So I promised we talk about the status of our office during this pandemic. As you know, like many other businesses, we closed our practice about 2 weeks ago in response to the governor's order. Even though we're an essential practice because we're a medical practice, we felt that it was in the best interest and safety of our patients and staff to close so that we did not spread this disease or unfortunately, pass on the disease to anyone else. So many other practices did the same thing, and I commend them for that. But just because we're not in the practice physically doesn't mean that we're not interacting and responding to our patients. We're definitely fielding emails, and you can reach us at info@osocortho.com. You can also text us at our main number, which is 248-335-2977. You can catch us on social media. So I'm just looking at the comments to see if there's anything if you're error loading the messages, okay. Oh no, are these not, is it working? I'm hoping it's working. So if someone can comment, can you see the video? And you can see the stream, I hope. We're going to put up our contact information. There it is, actually. You can reach us at those in those areas to contact us. So, oh, I hope that's contacting. So we'll have to see. It seems like it's streaming on our end, so hopefully it's working. Oh, good. All right. Looks like it's working. So we've got some comments saying that it's working. I appreciate that. So again, use our contact information. We are fielding text messages. We're fielding emails. Thanks, guys. And we're also checking in on voicemail, but that's probably the least efficient way to get a hold of us. The doctors are all on board. Every one of us is getting our messages from our patients. We're all contacting our patients. We've set the date of April 30th to try to go back to the office. Obviously, that's a moving target. It really depends on what happens in the next couple, 3 weeks. Again, we don't want to go back a minute sooner than we feel that it's safe for our patients and for our staff. Trust me, there's no one, I promise you, no one more eager than all 5 of us and our staff to get back to doing what we love doing, which is taking care of our patients. But that's, we will hopefully update you as time goes on, but our target date right now is April 30th. We're hoping that this is behind us by then, and we'll see what we can do with that. As far as surgery goes, I promised I'd update you. Again, as many of you are aware, especially those of you who had surgery scheduled with us, we needed to cancel all elective surgery, and that was under the guidance of the CDC as well as the Surgeon General and really all the specialty organizations. So I have a unique role at St. Joe's. I'm the chief of surgery at St. Joe's, so I'm intimately involved in the decision to cancel surgeries and as to when to have those surgeries done again. Right now, we have pegged a date of May 4th to go back to operating. I know many of you have wondered why we needed to do this, and I'm going to cover that in a minute. Just because we're not doing elective surgeries, please understand we are still doing emergencies and urgent cases that need to be done. I'm the one, myself and the chief of anesthesia, is screening all of those surgeries to make sure they're appropriate for the time. Many of you have asked what exactly defines elective surgery. How does that define? Especially if you're in severe pain, if you're immobilized, suffering, how can that be elective surgery? So first, let me define what elective surgery is. So elective surgery is best defined as a surgery for a non-life-threatening problem that delaying it will hopefully not cause any increase what's called morbidity or mortality, meaning any further problems by delaying it for a couple of months. And the reason to delay these surgeries may not be obvious on the surface, but all of us have heard about what's going on in the treatment with this COVID virus. And so just to explain why we needed to do that and why that was a recommendation from all the government bodies. One is that, there is a significant shortage of resources, and primarily the physical resources, but also the human resources. And so the personal protective equipment that we all use during surgery needed to be reallocated to taking care of these COVID patients. More importantly, it's the human resources. So when we take a patient back to surgery, we do utilize a lot of resources to make sure that the patients get in and out of surgery safely. And that's anesthesia, the OR personnel, and everyone else. During this time, all of those people from the operating room and the resources have been redirected to other areas of the hospital to help take care of these very sick patients. And just again, as we said, just although we're not doing elective surgery, several of our members in our group are taking trauma and emergency call and in fact have operated on patients during this pandemic. Unfortunately, patients who are COVID positive, making sure they take all the necessary precautions to protect themselves, the staff, but also the patients. And you can imagine the recovery for these patients having to undergo a major surgery, but also having to deal with this disease has not been easy for anybody. But we are still in the hospital taking care of patients and doing what we need to do as we are all kind of coping with this pandemic. At this point, we're just going to cover some things about arthritis, which is what I do, hip and knee arthritis. Like I said, myself and Dr. Joseph Ward in our practice specialize in this. And what you can do at home to maybe help with this condition. I know a couple of the messages we've gotten about, what can we do to help ease the pain of arthritis. first, I think it's important to talk about what arthritis is. And so I always try to break it down to just very basic terms. Arthritis just means inflammation of the joint, literally. And really what we understand it to mean is that when the cartilage is breaking down in the joint and the patient is kind of having the symptoms from that. And what happens is you take out that cushion effect between the two bones. And what ends up happening is the load starts to cause inflammation and irritation. And so the symptoms of arthritis are things like swelling, pain, stiffness, immobility, meaning that you can't do your daily activities or the things you need to do to get by. And so when that happens, the patients start to suffer from this. And so there's some of the things you can do. I'd like to use the acronym of RICE, R-I-C-E. It's usually used for injuries, which is rest, ice, compression, and elevation. But we can apply it to arthritis in this kind of condition that we're in now where we can't get into the offices. And so rest can mean decreasing the load or the pressure that you put across the joint. And that can be done by avoiding high impact or high load activities. And what are high impact, high load activities? Like jumping, running, climbing stairs, particularly up or down with a load in your hand, like a laundry basket or something else. Obviously, if you have stairs in your house, you have to do stairs, but minimizing that will help decrease the inflammation and the irritation as best as possible. So the other one is ice, and probably one of the most common questions we get in our practice in general is when is it best to do ice? When is it best to do heat? When can we do both? Is it one versus the other? And the answer is yes, all of that. So it's you can do both, and typically we recommend ice, particularly when the joint's inflamed or irritated, if the patient is having pain towards the end of the day. So the way I like to explain it is this. When you put your hand into a ice bucket or bucket of ice and water, you pull it out, the hand is white. That's because the blood vessels have constricted. There's no blood getting to that area. And that's essentially what we're trying to do when we ice down an area. And so what happens what happens with that is to decrease the blood flow to the joint, so there's less inflammatory factors being taken to the joint. And so the ice, typically when the joint's inflamed, irritated, and it could be a muscle, tendon, any area of the body that's irritated, ice typically for that. Now, there are some indications for heat, particularly if you're going to, say, get moving or get active. So typically heat will help, and that could be done with massage or friction rub on the joint or the muscle, taking a hot shower in the morning to kind of loosen things up. Nothing wrong with that, and that actually kind of helps things as well. Compression, the C, is the next thing. So compression applies to joints where you can actually wrap or put a compression type dressing on them, like a knee sleeve, which is the pull-up kind of sleeve that you put over the knee. We like the ones with the hole in the middle to let the patella come out. And that just helps contain the joint, take away swelling and prevent swelling from occurring. And, it's easy because if it works, great. And if it doesn't, you can just take it off. It's kind of what I tell my patients. And then elevation. Typically patients with arthritis, particularly in their lower extremities in the legs, such as the hip and knee, will end up with swelling at the end of the day because the joint's swollen, irritated, pressing on the veins, and doesn't allow the fluid or the blood to get back. And so when that happens, you can elevate the leg at night. You can try to get some of that swelling to go down. And so it can help with irritation and pain and hopefully make for a better day the next day. So that's the first line of treatment. The next is medication. And I just got to say that before taking any medication, I'm going to go over a couple of medications you can do over the counter. Please check with your doctor, whether it's us, the orthopedic surgeons, your primary care physician, your family practitioner. Do not take any medications, even though they're over the counter, without checking with your doctor first. But there are two types of medications you can take for pain, at least when it comes to arthritis. Initially, it's Tylenol. Tylenol is a pain reliever, and we call that a central acting medication. And what that does is that medication helps act on the brain to take away pain. It's a pain reliever. And so you can take that. The next one are anti-inflammatories. And there are two types of anti-inflammatories available over the counter. It's ibuprofen, which is known as Advil, Motrin, IB, those kind of things. And then there's Aleve, which is naproxen sodium. And both of those come in the trade form and then in the generic form. They're dosed differently. I read the box for the recommended dose over the counter. We can prescribe them in much higher doses through a prescription. But again, I would strongly urge that you do not take those medications without checking with your medical professional, whether, again, it's our office, if you're one of our patients, or with your primary care physician. Those medications can affect your kidney, liver, stomach, and they can also cause bleeding if you're on blood thinners. But typically, again, you can take those medications to help decrease inflammation. They're not a cure-all, they're not a panacea, but they do help with this condition, with arthritis for sure. We can prescribe anti-inflammatories, things like meloxicam, Celebrex, diclofenac. There are plenty that we can choose from. When the patient is still having pain in spite of having taken anti-inflammatories, next is injections. And there's really just two types of injections that we can administer and for arthritis. One is cortisone. Everyone knows about cortisone, has heard horror stories about it. I can tell you when we do cortisone, usually it's very efficient, hopefully with minimal pain. And you guys can comment if you've had one with us, how easy it was. But typically cortisone, think of it as an anti-inflammatory that we deliver right into the joint. And what that does is help take away the inflammation and irritation in the joint. It can act for several months. Sometimes it may help longer, sometimes not as long. It just depends on the inflammation, the type of inflammation, and so forth. But it's definitely a good option if you're hurting. When we're back in the office, you can be sure that we'll be doing plenty of cortisone injections. And then there's another injection, which is a lubricant called hyaluronic acid. A lot of patients know it as the chicken fat or the chicken gel. And so what that is help lubricate the joint. A lot of people get the impression that it's helping rebuild cartilage, cushioning the joint, protecting the joint. It really doesn't do any of that, unfortunately. It'd be nice if it did, but it just helps cushion the joint so that you don't have as much inflammation. I'm sorry, it helps lubricate the joint so you don't have as much inflammation or irritation in the joint. And so therefore, decreasing the symptoms. Again, it's short-lived. It can work up to 6 months, but it hardly ever works that long. But again, we can talk about that. And then obviously there's hip and knee replacement. When all that fails and we've reached the end of the line, we can talk to you about hip and knee replacement. And I know in our practice, when we get to that point, it's a conversation with the patient. Just like we've talked about, this is elective surgery. We want to make sure the patients are all kind of informed. Part of their treatment, our best patient is the well-informed, engaged patient, and we make sure that we are available to you. We communicate with you because really, I always say, I do the surgery, but the people who are really going to be going through this are the patients. And so we make sure that you are teed up and ready to have this surgery and set you up for success for when we do this surgery. So I know there's been some questions. I don't know how people do this and are able to read the comments. I'm maybe getting old and I can't multitask. But so there were some questions that were asked in the announcement. I think Mary Jo had a question about some rehab for total knee. And especially now since some of the therapies locations are closed and also the gyms are closed where you can get to the thing. So what can you do at home to help rehab your total knee or just to get the knee moving? So one of the best exercises I like to recommend is a bike. One of the nicest things or one of the best things to do is to use a bike to get the knee to bend. And the way I like to instruct my patients on how to do that is to start with the seat high and just to be able to get the knees around, especially if you've had a knee replacement recently. Then start lowering the seat or move the seat closer if it's a recumbent bike and get that knee all the way around. If you can't get it around, you can go back and forth on the pedals until you can get it around. The way you know you're making progress is if that seat is getting lower and if the seat is getting closer to the pedals, then you know you're getting that knee bent more, and so therefore you're getting more range of motion. You can do a lunge on a stair where you put your foot up on a stair and then lunge into it in order to bend the knee. That typically can help with the knee range of motion. That's kind of using your body weight to bend the knee. And then heel slides, which is where you put your foot down on the ground and just kind of slide it back, sitting at 90 degrees. And you can even hook it with the other foot, with the other leg. We are going to put up some videos on knee exercises that demonstrate some of those exercises. I think they already did. My helpers did here. I'll hopefully introduce you to them when we're done, the Kassab clan. And you can go through those videos. And then again, if you have any questions or concerns, I'm happy to answer those privately, trying not to address any specific patient requests or questions at this point, just for privacy's sake. There was a question about having bilateral knee replacements. And again, that's kind of comes up in our practice often. Do I need both knees done? Why not just get them done at once? It's one surgery, one anesthetic. It's easy, right? The problem with that is it's a higher risk when you do that. So we take a procedure that's very successful with low risk and honestly just add more complication to it and maybe take away the success that we typically would have with a single knee. So the way we practice is we typically do one knee, get the patient through it, and then we help get the patient guided through the recovery, and then get them through, and then do the other knee within 6 weeks at the earliest, but typically about 3 months. And again, it just lowers the risk. Studies have shown that if you wait that long, you kind of reset the risk for surgery, even though it's very small. You just don't want to increase it unnecessarily. So that's why we don't try not to do both knees together. And then again, anyone who's had a total knee, usually before surgery, everyone wants both knees done together. After surgery, almost nobody can imagine having had both done at once. And so for those reasons, we try not to do it, together. And then elective surgeries, I think another question that was raised by Sue, elective surgeries in May. Like I said, we're pegging a date of May 4th. What we're going to do at that point when we go back to doing surgery, so imagine it's not just us that have had to cancel surgery. Every surgeon has had to cancel elective surgery. And again, in my role as chief of surgery at St. Joe's, we've asked all the surgeons to already start thinking about what surgeries they think need to be done first, meaning that, which of their patients they want prioritized. And we're going to allow the surgeons to decide that. That's not for, the hospital or anyone else to decide. I know the way I think we're going to handle it is have a one-on-one conversation with our patients, either ourselves or through our schedulers, and try to get as many of the cases done, or surgeries done, after that May 4th time frame. And again, that's assuming we go back at May 4th. But I can tell you again, the minute we open up those floodgates, there are going to be a lot of people who want surgery, and a lot of surgeons who want to do the surgery. So hopefully we'll be able to get to the scheduled cases in May, but it's just difficult to tell right now until this thing kind of settles down a little bit. So trying to look at some of the comments. But it's not better. Okay, so some of the comments, and then again, some of the specific comments I promise we'll address. I just don't want to do that necessarily on the thing. So are some comments. Judy saying about her cortisone lasting 9 months. Typically, it's about 3 months is what it lasts. Again, we reassess the patient at that point. Cortisone isn't something we can just keep on doing. Typically, it stops working after a period of time. And it's not that the cortisone is getting any weaker and doesn't work, but what ends up happening is that the cortisone starts to wear off, and the disease actually the arthritis starts to get worse. And so therefore, it's just not as effective when you do the cortisone. It's not as good as being in the office. I know Brenda said, thank you for doing this live stream. It's not as good as being in the office, but honestly, it's, the next best thing, I guess, at this point when we're doing this, this way. Are there any other comments? I kind of lost the comments section on here for some reason. Maybe it's coming back. Okay. If you have any other comments or questions, please feel free again to either email us or text us at our main number, 248-335-2977. The comments section are not here, so okay. Do you have them? All right. Well, thank you. Julia's going to give me her computer. Jules, thanks you. All right. Can we use stem cells? Yes. So stem cells are interesting. Thanks, Jay, for my comments went out. So daughter, Julia, come here for a minute.
Ow.
This is Julia, my daughter.
Everybody,
there you go. There she is.
Okay.
Many of you may know her only because she was born about, 19 years ago almost. A couple of my kids were born on a Tuesday, which was my surgery day, so I needed to cancel surgery to go have a couple children. Hey, Jay.
Hey.
Okay. There we go. So about stem cells. And so we don't do stem cells in our office for the most part. We do use some other alternative therapies like platelet-rich plasma. I would advise you to look at the FDA website on their directive and commentary on stem cells. At this point, what I can tell you is there is no proven benefit to the stem cells that are being used now. It's not to say stem cells are not beneficial. They're in certain medical indications, particularly things like cancers of lymphoma, leukemia, they get stem cells. Patients who have Parkinson's have gotten some stem cells successfully. But when it comes to arthritis, there's just been no real proven studies to show that they benefit. Now, some patients have gotten it; they've benefited from it. We've really not seen anyone who has kind of regrown cartilage because of stem cells. They may feel better, but their joint doesn't come back. And again, I would just tell you to do your due diligence on doing that. A lot of this is out of pocket and honestly is unproven at this point. So there we go. And so I'm just trying to go through the comments to see if there's anything that I can address. Again, my comment section stopped working. Hi, Julia. Somebody put high tech. Yes, Julia has a lot of hair. She gets it from me. My mom always tells her that I used to have hair like that, which is kind of hard to believe. Happy again to answer any questions or concerns. I really do wish this was a two-way conversation. I function much better that way. For those of you who know me, I like human interaction, just like I think most of us. So a couple questions about appointments that have been canceled. If your appointment's been canceled and we have not gotten back to you, please email us or text us. We did, so just so our system works, we sent out kind of a notifier to all of our patients that had appointments that just said your appointment is canceled, and expecting that we would call them when we're able to reschedule it. But if you have a specific concern, a specific question, by all means, email us at info@osocortho.com or text us to our main number, 248-335-2977. And just like our office hours, that's being checked, I think around 8 to 5 or 9 to 5. And we'll get back to you through a secure messaging or call you if there's a concern. So, and Mary Jo is asking about nerves regenerating. And RPT steps, everything. So the nerves regenerating, I don't know if that's specific to total knee. So nerves regenerate just in general. This is from what I remember in medical school, about 1 millimeter a month, which is a very, very, very small distance. And so when we do a total knee, sometimes there's a numb area. I'm answering a question that someone asked about numbness on the outside part of the knee and nerves regenerating. So there's a very small area on the outside part of the knee that becomes numb because we cut through that skin nerve. It's not visible to the naked eye, and we cut through it, but then it regenerates. It can take 3 months, sometimes up to 6 months. It really just depends, and usually it kind of regenerates end to end. Sometimes it can do this, and so therefore it becomes kind of hypersensitive in that area where that nerve is sticking up in the skin. And over time, that usually goes down. It may be left with a very small numb spot on the side of the knee. If you've had a total knee, you know what that is. But otherwise, it's usually should regenerate. Technical answer is 1 millimeter a month. Typically for the total knee, we usually could see that in about 3 months or so. We see that nerve endings come back. Mark says, ouch, from his nerve regenerating. Yes, when that nerve points into the skin, it definitely it's hypersensitive. Patients will complain because they either, it's one of two complaints. It's either I can't feel that area or that it feels hypersensitive, meaning I can feel it too much. Trying to look through some of the comments here. Hello to all of you. Scheduled knee surgery and been told that I need an ankle replaced. Cortisone injection, my ankle, more painful than my knee. Both done at the same time. If there's a question about someone who needs both the knee surgery as well as an ankle surgery, if you're asking about whether they're having cortisone in 2 separate joints, that's a great question. We get that a lot actually in our practice as well. If a patient of Dr. Bahu's who got a shoulder injection, and they come next day or next week to me and get a knee injection. So typically it's very safe to get cortisone injections either on the same day or very close together if they're in separate joints. And so the best example is that when we do both knees, we give cortisone injections in both knees. So as long as they're not in the same joint, it's very safe to get that in the same day or the next day or in close together. Typically in the same joint, you want to wait minimum 3 months, and that's just a rule of thumb. The longer you wait, probably the better. And if you're going to have surgery, which a lot of patients who are getting cortisone injections are going to probably need surgery, and that's why they're getting the cortisone injections, because the knee or the ankle or whatever it is hurting them too much. We typically, again, as a rule, like to wait a minimum, and some of the studies have shown that a minimum of 3 months, so that there isn't a higher infection risk with surgery, maybe even longer than that, ideally anywhere between 3 and 6 months. So our cutoff is 3 months. If you've got a cortisone injection in the joint that we're going to operate on, I'm going to speak for myself and Dr. Ward as far as hip and knee, we wait 3 months primarily. And so just trying to get some of these things. I know a lot of you are out there, a lot of our patients. Can't wait to get my knee replaced. Awesome. That's the attitude to have. And our patients do well. I'm not bragging about that, but we are meticulous when we do our hip and knee replacements, all of our surgeries, all of our specialists. And that's the reason we are who we are. We don't accept anything less than that. And so we take pride in what we do, and we definitely, again, try to set our patients up for success. It's not just about the surgery. Actually, our surgery starts 2 months, 3 months before the surgery, whether it's introducing you to our therapist, getting you in our office to do the education, or going to St. Joe's to get the education, seeing our providers to discuss any questions, to make sure you're 100% ready to have the surgery. And when the surgery happens, it's just smooth sailing, hopefully, after that. It's still surgery. Don't get me wrong. I never, ever let my guard down. Any of us let our guard down. All of us who operate, very much understand the risk of surgery. And so that's why we never let our guard down. So people are asking, when are we going to go back to elective surgery if they missed the first part? So I'm just going to review that. So our office is closed till April 30th. Again, that's a very soft date. We're evaluating that almost daily. All the doctors talk maybe 2-3 times a week and kind of plan. Today we had a planning meeting about when we do go back, how are we going to coordinate going back to the office. So just because it's safe to go back to the office doesn't mean that this virus is gone. So we are going to have to take some special precautions. But right now for our office, we're planning on going back on April 30th. For elective surgeries, which is what Karen was asking, May 4th is the date we've set at St. Joe's. Again, it's a very soft date. We're looking at that one hourly almost, just to see what kind of spikes and surges we're having at the hospital with the COVID-19 patients. We don't know. We haven't peaked yet. I can tell you at St. Joe's, we're still seeing patients. But as far as at this point, we are anticipating May 4th. That date may get moved, but just like the office, just because it's, we're going back to surgery doesn't mean this virus is gone. And again, we're going to have to take precautions, gear up the operating room to handle all the patients that have been delayed. And again, it's not just orthopedic patients. I can tell you, as in my position, every service, urologists, neurosurgeons, plastic surgeons, the oral maxillofacial, the oral surgeons, everyone has had to put out their non-urgent, I should say, or emergent surgeries. And so therefore there's going to be a huge backlog when we go back, and we're going to try to prioritize that the best as possible. All right. Hopefully that answered. Questions? If there are any other questions or concerns I can address. I know a couple of our therapists are on this feed and commenting and addressing, and I appreciate that. I'm going to give a shout out to Janice. Many of you know through Clarkson, and Denise, who from Clarkson PT, who are just amazing and awesome and take great care of our patients. And I know they're commenting on this, as I can see. Embody. Okay. All right. So if there are no other comments or questions, I hope you all enjoyed this. I hope this was meaningful. We're going to try to do more of this, especially in the situation we're in. We're all longing to communicate with our patients and stay in touch with our patients. We're orthopedic surgeons. This is what we know how to do, is take care of patients. And like I said, we all dearly miss it. I appreciate all of you tuning in. Please send comments, feedback, whatever you want. I'm happy to answer it. Everyone in our practice is more than happy to answer it. Again, our contact info is there. So any comments or questions, happy to address. Look for our social media. And any concerns or anything like that, again, any specific patient questions, we're going to look through the comments and hopefully reach out to the patients and address that. All right. Lynn and Roger, who work in our operating room, are on here as well. Take care of yourselves. Miss you guys. Again, all of us are eager to get back to what we do. Thank you all. Thank you all for joining. Again, I hope this was meaningful. Stay safe. Stay well. We will get through this. I have no doubt we're all going to be better off after this because of everything we've gone through. So appreciate it. Take care of yourselves.